everybody, and welcome to this episode of Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association. It is May 10th of 2024, and I am joined by a very interesting and intriguing woman, Jan Berger. Welcome, Jan.
Hi, Lisa.
It's so good to have you here. So Jan has a really interesting background, and I'm going to announce her and introduce her by the author of a book called Re-Engaging in Trust, The Missing Ingredients to Fixing Healthcare. Here's the book. Here's my dog tags. If you're listening to this on podcast and you can't see the visual, sorry, but for those who can see the visual, they see I got my little flags in here and I got lots of questions I want to ask Jan, but I'm going to ask Jan to tell us a little bit about herself from the professional side. And this story, ladies and gentlemen, is going to take a twist. So if you're listening early and you're like, oh, I'm going to listen to an author about a book on trusting healthcare, oh, it's going to get more interesting than that. Jan, tell us about your career, your background, and what led you to write this book.
It's interesting. If somebody tried to follow my career path, they would be very confused. It's kind of like the LA highway system. It goes all over the place, and sometimes it speeds up and sometimes it slows down. I am a pediatrician by training. I do not come from a healthcare family, but it's something I wanted to do my entire life. As a child, at 7, I decided and told my family I was going to be a pediatrician. As we traveled as a family, they wanted to go to this monument and this park. I wanted to go see the hospitals. I was a very odd child, but it was absolutely a path I was going to follow. And I did. The interesting thing is very soon after I started practicing pediatrics, as much as I loved it, I realized that I could make a bigger impact. So I started to go into administration, and I have followed a long career of different administrative paths with a health plan, with a PBM, with a large retailer, CVS. I then, during that time, I spent time in Washington. I then left them in 2009 and started a healthcare consulting company where I have worked in 14 countries and have helped write policy twice in Washington. Once with Medicare Part D and then with the Affordable Care Act. And so I've done a little of everything. But going to the book, in 2016, we were starting to see some interesting changes both in society and in healthcare. If you remember, we were going through a very contentious political time in the United States. And with my consulting work, I realized this breach of trust that was occurring. And so myself and a colleague started to do some data collection. And we realized after doing a survey of 2,000 individuals from all of the 5 stakeholders in healthcare.
Let's define who they are.
I was going to do that. I like to call it the P's. The payers, the providers, the policymakers, the pharmaceutical makers, and the patients. And the interesting thing about that is healthcare is the only place where the entire country is a stakeholder. Because if you're not working in it directly, then you may be working in it indirectly. And if you're not working it indirectly, a family member or yourself somehow at some time is a patient. And so I reached out to everybody, and the data was really weird. And I also ended up in the hospital with a GI problem. I had a GI bleed and ended up in the hospital in December of that year. So the whole study got put on hold for 3 months. So part of my data was during the election, part of my data was after President Trump became President Trump. And the data was odd there too. So I went and interviewed 300 people, and I realized we had a big old problem. The other thing is, and I started to write the book. Well, I travel a lot for work, and the book got only half written. Fast forward it to COVID, and I'm grounded. I'm at home. So I made a deal with myself that I would walk an hour and a half each day. I would write an hour and a half each day. And that way I got my second glass of wine during COVID each day. We won't go into that part of the conversation. But over a 9-month period, the book got finished. And May of 2021, the book came out. So that's the story of, because I've worked in so many areas in healthcare, And because I am trained as a pediatrician, which makes me a pragmatic optimist, I didn't just take the data. I gave 15 things we could do as a system to improve trust. So that's the story.
I found a couple of pieces of the book particularly perplexing and weird, as you say. So the levels of trust, and this is 2017. We do have to look at this through two lenses, the pre-COVID, the post-COVID, because we did a big old switch off here where we stopped believing in science. A lot of people, they stopped, it was more, what can social media teach me rather than what does the science say? And we started to get our data from a different place, and trust got even more eroded. But in 2017, and I'm particularly looking at page 158 of your book, it was, what is the average range of satisfaction, I guess is the best way to put it, in our healthcare systems, the level of trust we have there, our physicians, and our health plans. So a lot of times a patient is thinking of the hospital, the doctor, and the health plan kind of as one. And unless you're, in a closed system like a Kaiser or UPMC or Geising or something like that, they are three different entities in most cases. There's three different levels, and the average range of trust, the low end was the health system at 52%, and the highest was the health plan at 59%. And I find it absolutely amazing that the plan is the payer, and there was more trust in the payer than the actual hospital system or the physician, which was only at 55%. So you were trusting your health plan more than your physician?
Well, because they paid. They were the money. They were the bank. Interesting. And you talk about pre and post COVID. And I have continued to do data collection and interviews even since COVID. What we saw during COVID is the physician, actually, by the way, pharmacists and nurses are more trusted than physicians. Mm-hmm. But that is changing. I just saw
where that came
from. I have no idea, but I love it. But the thing about that is pharmacists are losing trust because of what's happening at the retail pharmacies. Post-COVID, employers were the most trusted entity in healthcare. Employers. So things do change, and that's why I collect that. Physicians went down because physicians weren't available during COVID. What we have seen is the relationship between trust and physicians skyrockets after they've been in a relationship for 18 months or more. So the transiency of healthcare, meaning, do I have the same doctor? Do I have the same nurse practitioner or PA? How much time do they give me? Those are the things that help us to see what rises and what doesn't during times of trust and distrust. The other is pharma was extremely trusted during COVID. It went up to the levels it had in the 70s and 80s when pharmaceutical manufacturers were very trusted. Pharmaceutical manufacturers saved our lives during COVID.
They did. And I am a 5 times vaxxed individual for the COVID vaccine.
Me too. I must admit.
I believe the science, and I believe the integrity of the researchers involved. Were they perfect at all times? No. Did the information flow perfectly? No. We were living in live time with new science, and it was a complicated time, which I think made everybody stop and think again, wait, how much do they really know, and what are we learning together? And we have this unrealistic expectation, in my opinion, that they should know everything and they should provide it to us. Well, they are humans, and they're learning in live time, and they're trying to treat people in live time. So we have to have realistic expectations and realistic risk tolerances. And we have to make sure that as we go through those processes, that we're not only taking care of ourselves, but we're taking care of society, and that we're being good stewards of this health information. On page 162, when you start breaking down like these different levels of trust, hospitals and hospital systems, you go through a list of 9 things that they've been elucidated, they've been identified as areas of concern, and that is lack of transparency and cost, higher cost compared to similar services in other centers, surprise billing, aggressive collection, long waits in ERs, media coverage of medical mistakes, TVs and movies where profits play over people and all the drama. There's this whole underculture of why we distrust and what we need to know. But what has happened since you wrote this book that might help to open up some of these areas of distrust and improve them?
So a couple of things. I'm a pragmatic optimist. So we can't fix everything, but if we are evolving in the right direction, it gives me hope. So a couple of things. We got the Consolidated Appropriations Act of 2022. So what does that say? It's a big term. By the way, I call it CAA. Much easier because half the time I can't remember what the C and the A stand for. But what it's come out and said as part of it is there needs to be greater transparency in healthcare. I won't go into the depth of it. That's the so what, now what.
Perfect.
And what that means is, and along with that, along with surprise billing support, which came up since that time, these two things alone help us to at least know what's going on. When we're told, it is human nature, if you aren't being told things, there's two consequences. One is you can't make a good, thoughtful decision.
Nope.
We go buy a refrigerator or a car, and I spend hours in Consumer Reports, hours. Now, I may in the end not choose the best quality because the other one's really pretty, and then I regret it later. But we have the information, we have the quality information, we have the cost information. How do we make good decisions on the most intimate, vulnerable, personal thing we have, our health and our family's health, without it? And then the second issue is, do you know that almost half of our country gets bills that they don't expect from healthcare, and that 40% of the country, I heard you are medical debt, Mrs. Medical Debt.
That's me.
I heard you. See, I listened to your podcast, including at the grocery store this morning. But none of us like to have to choose between feeding our families and taking our medicines or going to the doctor. So surprise billing definitely helps. We still have terrible problems with access to care, wait times, whether it's the emergency room or our doctors. There's no question. The press, bad news sells. So TV and everything else. And I'm one of those people, even though I've spent 66 years on this earth and 40 of them in healthcare, I still watch TV shows about healthcare and I try to guess the diagnoses. And so, I know what's real and what's not.
We have a list of problems. Mm-hmm. We have a very divided culture in this country right now. And many people are arguing over healthcare access, but I keep coming back to a couple of very simple points. We are creating systems that make the system more expensive and more confusing and less focused on the individual person and their lived experience and their current needs. You were kind of in the earlier days, I won't say the earliest days, but the earlier days of PBMs. I used to be a health plan administrator, and they were sold to us as, this is great. You're going to save money. You're going to get the same quality, and we're going to save money for you by giving you these rebates back. And as the employer back in the late 80s, early 90s, the plan got this money back and we were able to improve benefits because it brought down our costs. But those fees back to the employers kind of dried up and they went down another line, and there's not really the same types of cost sharing. And frankly, patients like me who have very expensive medications, I end up supporting patients who are not ill because the kickbacks, and I call it kickbacks on purpose, but the rebates that are coming back from my expensive meds are funding healthcare for others. I didn't think that the sick were supposed to cover the well like this. I'm confused. Help me understand PBMs in 2024.
So I will say, it's funny. I have been in healthcare inflection points a number of times in my life. I worked for a staff model HMO in Chicago. It was amazing healthcare. I live in the neighborhood I worked in, and patients who see me now, 30 years later, still come running up and talking to me, and actually called me during COVID and said, what should I do? I'm not the person you should ask about medical things today, but that was one inflection point. And as you said early on in the PBM industry, what we did was really good. The science was different. We didn't have the biomarkers. We didn't have pharmacogenetics and pharmacokinetics the way we do. And so we were doing really good stuff. What has gone in my mind offline, and I've been very public about it, formularies have lost the science foundation. Healthcare has gotten more and more personalized, more and more specific. And the systems that were set up in the 90s and early 2000s with traditional PBMs and then specialty PBMs, I'm very proud of the time I was there. And I learned a lot, and an amazing amount. But we have to change how formularies are made. We need to not make formularies based on who can pay the highest rebate. We need to attach the right patient to the right drug at the right time. And sometimes it's the right drug, except for the fact they're on 2 or 3 or 4 other drugs, like your cocktail of drugs or your recipe of drugs. And therefore, what otherwise would have been the right drug is no longer the right drug. Okay, and that's the pharmacokinetics. I like to say it depends on how many cars are on the highway, which direction I take. It's the same way with your medicine. And we have to fix that.
We've turned the PBMs into a revenue generating system as opposed to a better access point for patients to get their meds.
Yes.
It's more about the monies than the meds.
Yes, we've lost our way a bit as the science has advanced. Absolutely.
And we need to find our way back. Later in your book, on page 273, and we can take deeper dives in future podcasts because we've got another part of the story to get to. You used a quote in your What Can We Do to Make It Better 15 list. And under compassion and empathy, you are quoting a chief experience officer at a health system who said, stop looking at scores and start loving. Mm-hmm. And my note in the book was, is this possible? We've got nurses who are overtaxed, doctors who are overtaxed, healthcare systems that are running into serious debt. You've got payer systems that may not want to always pay what the costs actually are. You have PBMs who are trying to filter money this way rather than that way to patients. How do we bring compassion and love back into the caring for our fellow human beings? How do we do that?
It's a great question. I would argue often it's not the individual's fault, it is the system's fault. We have created a system that doesn't give people the time. And I love that you didn't blame just one of the 5 Ps. It's rampant. You know, on individual levels, there are people, whether they're nurse practitioners, doctors, pharmacists, healthcare, even policy people, there are lots of people who do care and remember what it's all about.
There are definitely good people out there, but how do we give them the space to be their best?
We have to start looking at the system and seeing what's creating the barriers to the best. But that also includes patients, because we are part of the solution, but we are part of the problem. And we have to be a little realistic. I'm not always realistic, especially as a patient. I'm an impatient patient, but we're impatient because we're scared. We're overwhelmed. And so I would argue, and you'll laugh as I say this, all of us have to remember that we have a family member or ourselves when we are vulnerable and sick or get a diagnosis. And that often is the factor that change, along with the system having to change. We have to take a minute and say, oh my God, what if it was me or my mother or my husband or my wife?
And that enters my segue.
You like that segue there?
That was well done. Well set up, Jan. Some of you might be wondering, why am I talking to Jan? Well, I work in healthcare. She wrote in healthcare. We're talking about something that we're both passionate about, but that's not how we met. I got a message from one of our board members / ambassadors that through their social media feed, they came in contact with a person who lived in their community, the Chicago area, and had been recently diagnosed, and they had a really interesting background, and I should probably talk to this person. Knowing that physician, treat thyself is a very complicated place to be, I purposely had Jan go through our very traditional system of intake and navigation call. And I very specifically did not say, wow, you've got this great background. Let's talk about what you think about healthcare. No, we didn't discuss that. I said, okay, Jan, tell me about the first time you heard the words hypertrophic cardiomyopathy, and we start from there. So Jan, when did you first hear these words and how does it impact you?
September 10th, 2023.
And what happened?
I went to my internist a week before, who I've seen for 5 years, and who, by the way, is empathetic and compassionate. She is wonderful.
Send her my way.
And she said, oh, you've got a murmur. It's probably nothing. She knows I'm very active. I swim, I hike. I had just spent a week hiking in Italy. She said, it is nothing, but let's just check the box. So I went and got an echo. And 24 hours later on my chart, I got my echo results.
Oof.
And I didn't believe it. So I went into denial, said it's a mistake. And she called me quite quickly and said, we need to get some more tests. And I am going to refer you to a specialty cardiologist. Now, I'm very lucky. I'm in Chicago. And there is a center of excellence. But as we all know, it takes time. And I am very lucky because it only took 2.5 months to get into the COE. And in that time, I was a hot mess. And then during that time is when Lisa and I spoke. I am also very lucky that my niece's father, so my nephew is married to a young lady. Her father is a cardiologist in Kansas City.
Oh, that's right. I forgot about the Lauren connection.
And so anybody who's listening, it's Lauren Berenbaum in Kansas City. And I reached out. I don't do this often. I reached out to his daughter and I said, how do you think your dad would handle it if I called him? And she said, are you kidding, Jan? Your family. And between the HCMA, because I cried, I did everything. My emotions were, I'm a very optimistic person. I was a hot mess. I didn't want to get out of bed. I figured I was dying any day. I didn't understand it. I spent way too much time on Google, and Lauren was there and we talked, and that started my journey with HCM. Since then, between Lauren, between Northwestern, and my connections at Cleveland Clinic, I have 3 kind, compassionate people who care for me. And trust comes into play because you may say, why do you have 3, Jan? Because till you can gain trust with new relationships, I didn't trust any of it.
That makes sense. And you are really lucky that you have the access to the 3, and a lot of people don't have that.
Right.
So they have to learn how to trust a little bit differently. So you get diagnosed, and then through our call and through other conversations you had, we said, let's look back on life a little bit. Mm-hmm. When did this really start showing and you didn't realize it? So with clarity of understanding, when you look back at your life, what might have been some of the other triggers over the years that might have got you to a diagnosis sooner?
There's 2 potential trigger points. 2014, where I had horrible back pain, and ended up in an emergency room. I'm a healthcare consultant. It was not an emergency room in Chicago. It was in Boston, and spent several hours there. And they said, you have a 1st-degree heart block, but everything else looks great. Go back to Chicago. Went back to Chicago. Had a stress test. It was absolutely wonderful. It was absolutely fine. And the 1st-degree heart block was gone and the back pain was gone. So that's number 1, 9 years prior to diagnosis. The second was 2 to 3 years prior to diagnosis, where I, again, started a couple of things I came up. Number 1 was this back pain again.
And where was the back pain?
Mid-upper back.
Mid-upper.
Okay. No chest pain. no shoulder pain. It was not back pain that, we all, especially as we get older and put on a few pounds, we all get back pain. I get some of that in lower back. This was different. It came and went on its own. I couldn't figure it out. I started to realize that going upstairs, I'd get short of breath. How many of you all have found that out to be the case? And I'd have good days and bad days, where all of a sudden, about a year before, I turned to my spouse one day and I said, I know I slept well last night, but I don't want to get out of bed. I got nothing in me. And I'm somebody who travels all over the world for work. I am an extremely active person. So for me to say that was very, very rare. Those were the things that really started retrospectively. I just thought I was a 66-year-old woman who was 15 pounds overweight. And so I was slowing down.
We blame ourselves because we gained some weight. Physicians are actually particularly good at telling women, well, if you lose some weight, you'll feel better. Well, yeah, no dope. But we also have hypertrophic cardiomyopathy underlying, and that makes it a little harder. So the good day, bad day situation is something that you have experienced.
Absolutely.
And is confounding as a patient and as a physician. We still don't understand the why we have these bounces. And that leads into something that I've been talking about for about 2 or 3 years now. And that's the New York Heart Association class scale. It does not work for us.
Right.
Because today I might be a 1, tomorrow I could be a 3, and in a couple weeks I'm a 2. So we bounce around the scale, which it's not supposed to be a bounceable scale. It's supposed to be a static number. So it's hard sometimes for us to communicate, like, I'm great right now as I sit in front of you, doc, but yesterday, getting to the mailbox was a real challenge. Mm-hmm. And a week before, getting to Cincinnati was easy. So how do you explain the two? So we're learning about that in real time yet again. We don't know it all. We are never going to know it all, but we're going to learn together. So let's take the Jan that gets diagnosed with hypertrophic cardiomyopathy, and the Jan who has this career and wrote a book about trusting healthcare. What are your thoughts about the system now that you've had to engage it, not just for an illness, but a chronic illness that's not incredibly common? Yeah, 1 in 250 have HCM, but only about 150,000 in the United States have been identified and treated so far. So we're kind of rare, but we're common. And you have this vantage point to look back and look forward. Where should we have been and where should we go?
It's interesting. I spoke earlier this week at a large consortium of employers called the Midwest Business Group on Health. And we were talking, one of the conversations when I was on stage was around what kind of support should employers give disease management programs, other programs, mental health programs for chronic disease. And I did something that I'm a pretty transparent person. And when you and I have talked, you've noticed that. We both are. It's kind of funny that way. But I stood on stage and said, hearing that you get a diagnosis that you are going to have for the rest of your life and it is changing your life is mind-boggling and overwhelming. And you've all heard me talk about it before, but I stand here in front of you this time and talk to you in a very different way. And these people all have known me 10 years or more.
Wow.
And I said, last September, I was diagnosed with a genetic heart disease called hypertrophic cardiomyopathy. And it has changed my life. And you guys can help me and help everybody else like me, whether it's the same disease or a different disease. And you guys can make a difference in our lives. Watching people's faces, and then the people who came up to me afterwards, because when you personalize it, people listen differently.
You do.
And I think whether it's peer-to-peer work, like what you do on the Facebook page. The good news is, since I've been diagnosed, I am not on the Facebook page 18 hours a day. And by the way, I was never, ever on Facebook.
I got you there.
Until the diagnosis. My wife and I fight about that all the I'm like, how did you know that? She's like, well, if you get on Facebook. And I was like, no. Well, guess what? Facebook saved my life in this case. So how do you do and what do I do and what's my next step? My next step is to still do what I've been doing, but with a very personal lens and a greater focus. Lisa, you and your team is amazing because you put up with me sending notes. I've got a new idea. I love
your ideas. Keep bringing them.
Julie laughs all the time when I do that. So greater focus. There's a woman by the name of Susanna Fox who recently wrote a book. She lives in Washington. She worked at HHS. And she is passionate about peer-to-peer. Susanna's a dear friend and a colleague, and I called her right after this diagnosis. And I said, all right, Susanna, I loved your book, but I get it now. Really get it. And so when I go and speak, and whether it's at a conference like this last week or sitting in a boardroom or anything else, those who are given much are expected to do much, and my much just refocused.
And we are going to take that knowledge and skill and passion, and we're going to help you use your passion and bring it together with HCMA. And I think we've got a couple of cool projects that we could potentially work on, which you're all going to have to tune in for other episodes to learn more about, because we're going to wrap it up and leave you on a bit of a cliffhanger here. Because I could probably, I literally, the house that Jan's recording in right now, I was there, about 3 weeks ago, and we sat for hours and just talked. Because I come from the grassroots patient advocacy community, the health plan administration from the small employer side, and 28 years of building HCMA into an organization that can provide support to thousands of people worldwide, hundreds of thousands at this point. Jan has her own point of view, and we both come from a point, re-engaging in trust. When I saw the name of the book, I literally laughed out loud. I'm like, oh boy, we're going to get along. Because in 1995, when my sister died, I lost all sense of trust of everybody I believed in and everything that I was ever told about this disease. And I found out that I was misled, that I was lied to, my sister was manipulated, and I sued the United States of America. Some people don't know that, but we've went forward with what's called a federal tort claim, which is you ask the government, can I sue you? And they say, sure, you can sue us. You don't sue the government for money. You sue the government to stop bad practices and to get better practices in place. And my sister died from mismanagement, which led me to ask a lot of really hard questions and change the complete trajectory of my life because I needed to re-engage in trust. Mm-hmm. And how did we do that? We built relationships with people, not institutions.
Right.
Some of those people became leadership in their institutions, and we're changing the culture. When I started with all my friends when they were young in their careers, well, now they're running the healthcare systems. And now they're bringing in institutional changes that'll change for generations how they experience HCM care. Currently 50 programs, stay tuned, a few more will be announced. We're doing some more site visits this summer. Building good care models, it's all of those stakeholders that Jan mentioned earlier with a focus on our community. And I'm looking forward, and if anybody who's in the employer groups wants to understand how they can service their patients better, call us, we can help. Payer systems, you want to know how to better understand the HCM patient, we can help. Clinicians, clinical trialists, physicians, we can bring education, information, and real life experiences so that you can blend it all together and we can reestablish trust. We want the patients to be trustworthy too. They need to communicate to their healthcare providers articulate information that is actionable. We all get lost in our histrionics. We all like to tell stories. I'm a really good storyteller. But when you get in front of that position, we need those moments, that clarity, that focus. And the faster you can get to focus on what your problem is, the faster we can get the clinician and the team to focus on how they can help you best. If we're ranting on these stories and we want to complain that we waited for 4 hours on the hold, well, we got to get them to not keep us on hold for 4 hours. because I personally spent 4 hours on the phone this past 2 weeks refilling my prescriptions. Whole other story. But we need to get efficient. We need to be articulate storytellers of our patient experience, our symptoms, and our wants. We all don't want the same things. Not everybody wants to go for a heart transplant. They'd rather go palliative care. And if that's what you want for your life, I'll support you 110%. You want to go to transplant? Let's go there. You want to go for your second transplant? We'll go there too if we need to. But some people just want to know which pill to take. Mm-hmm. And how often do I have to wear this Holter monitor or event monitor? Or do I really have to do the MRI? It's scary and I'm claustrophobic. Yeah, there's meds for that. We got you. We can help if we talk more, communicate more effectively, and bring around systematic changes. So Jan, I am really looking forward to changing the world with you. And I think we can do amazing things together. And I absolutely love what you're doing and that you're raising your voice in this very unique way. So thank you for being with us on Tales from the Heart.
Thank you. And thank you for everything you do and for bringing empathy back into healthcare.
Thank you. We try. Thank you to our sponsors of Tales for the Heart, who will be dropped in a clip here. It's with their support that we're able to bring you this wonderful programming and ensure that these voices are heard and that we all have a better understanding of how we can make the world a little bit better, one patient at a time, one encounter at a time. And I encourage you, if you're a healthcare provider, to take a moment and think about practicing with love. We don't talk about it enough. I've brought it up a couple times on this podcast. If we remember that we got into this for a reason, because we love people and we want to help them live better lives, that makes the hard days a little easier. Big shout out to a little girl out in Texas right now, Hannah, who's just been moved up to a 1A on the transplant list. I just want to give a big shout out for some good positive energy to head to Texas, to Hannah and her family. Thank you all and have a great day.
The Hypertrophic Cardiomyopathy Association takes this time to thank our corporate sponsors, Bristol Myers Squibb, Cytokinetics, BioMarin, and Tenaya Therapeutics.